Hi, everybody. It's Karen Anderson here with Aortic Hope, and we are here for a very special live Q&A. But before we get started, I'm going to ask you to click that like button, wherever it is on your screen. Click the subscribe button, hit that bell so that you're notified every time we go live. And as you know, we go live for Q&As, we go live for survivor stories, and we go live for our weekend review. And sometimes we just go live because I have a lot on my mind. But tonight, it's not about what's on my mind. We have two very special guests with us. We have Dr. Prakash and we have Kayla House, a research assistant. We're going to let them introduce themselves. And we are talking about research studies. We're talking about physical exercise. I know that's kind of like the political theme in the community. And then we're going to get to our regularly scheduled Ask a Doctor that we typically do on Facebook, but we're doing it here tonight. So if you're watching and you'd like to ask a question and you'd like it to remain anonymous, please send it to info@aortichope.org. Otherwise, you can post your very public question below in the comments section and we'll be sure to answer them. So thank you for joining us. Welcome, Dr. Prakash and Kayla. I'm going to let you guys take it away and introduce yourselves.
Thank you so much, Karen. We really appreciate the opportunity, and we're very excited to connect with you all about our clinical trial. My name is Dr. Siddarth Prakash. For those of you who may know me, I frequently answer questions on this forum in other ways. I teach and do research here at the University of Texas Health Science Center at Houston. And I also am a very passionate advocate for the community. I do a lot of work with the Marfan Foundation and with other groups, beds, and looking at ways that we can improve quality of life for people who are living with aortic disease. I also work on research looking at ways to treat aortic disease using medications. And of course, I see patients in our clinic here, aortic clinic here in Houston. So it's really exciting for me to get to talk about this. It's what I like to do the most. Kayla, go ahead.
Yeah, hey everyone, my name is Kayla. I am a Dr. Prakash's research assistant and also the research coordinator for this clinical trial. I've just had a blast getting to know a lot of members of the aortic dissection community, and I'm so grateful for this opportunity to get the word out about our research and to disseminate this information to you. So thank you guys so much.
Wonderful. A lot of people in the community want to know how they can participate, how they can help, how they can give back, what they can do to get involved. And one of the ways that we tell them often is they can participate in a research study. So people get confused on what that might be. They're not sure if they're going to be this poked and prodded guinea pig as stereotypically perceived. I want you to talk a little bit about this very well known now research study that you've been having. It's been going on for quite some time. So tell us a little bit about it, where you might be in the process and what, and everything that's just around it, what the goals are, et cetera, and how we can get involved.
Sure. I will share my slides. I have a few slides up here about the research study, and then we can go through and answer any questions people have. So this is an overview of our trial. It's called the multi-center because we're doing it at 3 sites in the United States, clinical trial of exercise in aortic dissection survivors. And this was started, as you mentioned, it was initially started in 2022. We've been recruiting since late January, and so we're still recruiting for the trial, and we are getting really good at this, as Kayla will attest. It takes some practice here. So this is the reason that the trial started, is really due to the community. These are some questions that people had asked me about exercise in my clinic. I have an aortic aneurysm. How can I remain active and have a productive and healthy life? What exercises do you recommend is one I get a lot. And after I've had surgery, what activities can I get back to? Is it safe to resume exercise and at what level? So these are questions literally every day I was getting asked. I'd look up, the guidelines. The guidelines had 2 lines in them, maybe. And most of them were very negative. It was restrict this, can't do that. And then when you look at the evidence, there was maybe 1 study about actually testing whether people could do those things or not. So it seemed like there was a big evidence gap, and that's what really motivated us to start looking at this problem. Because we know exercise for all kinds of heart and blood vessel problems is really good. It lowers blood pressure, it improves your endurance, it actually prevents death in all kinds of heart disease. it improves depression, and it increases confidence and reduces anxiety. These are all things that our patients, our community struggles with, especially if you've had a dissection. It's very hard to come back from that mentally as well as physically. And exercise seems to be almost the perfect antidote if you could get it to work. So the question is, well, what about the other side? Should we be concerned about exercise? And this was because there are lots of stories about aortic dissections related to sports or competitive activities like heavy weightlifting. There was no established safety track record. And so in the absence of that, people were being very conservative and telling people not to do any kind of heavy lifting or activities. And of course, we know that blood pressure tends to increase during exercise, and we're all told our blood pressure would stay low, should stay low. And so what does that really mean? This leads to a lot of anxiety and uncertainty about what is permissible and safe and what may not be safe. The other reason we went to do it is that a lot of our patients are not getting access to rehabilitation after having, say, surgery for an acute dissection. That's incredibly important because it can actually prevent a lot of future problems related to becoming weak and losing some muscle mass after you've been in the hospital. And we found only about 1 in 4 patients who's eligible in the US currently gets access to rehabilitation. That means a large percentage of people are never getting rehabilitated, and they may feel permanently weaker because of that. So this is really the statement that started it all. It says that basically people with any sort of syndromic or familial thoracic aortic disease should be limited to low static, low dynamic sports. And if you look at the chart, that restricts you to golf or bowling, okay? There weren't many other options on the table that meet low static, low dynamic. So it seemed like almost a non-starter with a lot of people. And so this meant, could we perhaps expand those indications and give people more freedom based on some real evidence? This is the idea. Now, fortunately, sex is in the low category, and that's a big point that I emphasize with everyone. But this low static, low dynamic, which is at the very bottom left corner, leaves out most things that people really want to do, especially if you're used to having an active life. So we started looking at this about 2 to 3 years ago. In our clinic, we just enrolled people who are willing to be tested. We said, we want to observe you to see if exercise is safe. We'll do it in our rehab facility, and we'll make sure we measure your blood pressure. So we did this with 31 of our patients, and we got 15 matched healthy controls. We did 3 aerobic and 3 moderate isometric exercises. We observed people for any problems, high blood pressure, symptoms, having to stop. And we wanted to see if they rated the exercises as difficult, if they had any problems related to completing the exercises. But actually, the patients did great. They didn't have to stop with any exercise. They were able to do everything that the controls were able to do. And so we felt very optimistic after observing this over a period of 18 months. And that led us to this clinical trial. The reason for this, as I mentioned, is that moderate intensity exercises are extremely important to stay fit and active. And so we thought they should, let's prove that they're actually safe for survivors of acute aortic dissection. Let's see if they can reduce anxiety and confidence to engage in activities of daily living. Maybe they can even reduce your blood pressure over a period of 12 months. And then a lot of times people who would not be eligible for things like cardiac rehabilitation might still be able to do a guided exercise program at home so that this could really expand access to exercise for more people. And so the objectives were: 1, measure the psychosocial impact of exercise using surveys about your mental health. 2, rate your self-reported activity level, depression, and confidence to engage in your activities. And we're measuring blood pressure over time to see if that goes down. So this is the conclusion criteria. You can have any sort of thoracic aortic dissection. You have to be at least 3 months out because we want you to be healed from the acute dissection. But after that, anyone is eligible to enroll. And you have to be able to attend 2 in-person study sessions at one of 3 sites We're doing it at the University of Michigan, at St. Louis, and here in Houston. And each of these sites, we are partnering with an aortic expert who's running exactly the same program, so the experience is identical. And we're going to follow you during the 12 months between the first and the second and the last visit to see how you're doing at home. So this is the trial. At the first visit, we enroll you in person. You sign a consent form and you complete questionnaires about your health history and your mental health. We measure your blood pressure. And then you're randomized. By randomized, it's like flipping a coin to either a guided exercise group in blue or a usual care group in red. If you're in the guided exercise group, that means that you're going to get an intensive home exercise program with check-ins every few months during that 12 months. You'll get one in-person exercise training session where we show you how to do the exercises and we observe you while you're doing them. And then at home, we'll check in with you until the last exercise session, where you'll repeat the process and we measure your blood pressure again. If you're enrolled in the usual care group, you don't get the in-person exercise training session or the virtual follow-ups, but we do provide you with counseling and a pamphlet about the recommended level of activity for people with aortic disease. And you can go to all of your regular care visits where you would get similar kind of monitoring for your aortic conditions. And in both situations, we want to see you at the beginning and end of the study. The purpose of doing it like this is that we need high quality evidence to convince the world that exercise is safe. And this is the accepted way in medicine that we show that an intervention of any kind, like exercise, makes a real difference in your life. We have to do this so that we have a control group that doesn't get the same intervention, but is alike in every other way to show that the exercise makes a difference. So the outcomes we're measuring, again, are improved mental health, increased confidence, lower blood pressure, and what we hope, if we continue this long enough, is that we can actually show that people who are more active have less problems with their aorta, fewer aortic dissections, fewer needs for operations, and slower growth of aneurysms. But that's a long-term goal. So this is where we are right now. We actually are extending the enrollment period a little bit. So it's going to be out to July. There's still time to sign up. Kayla will go through the dates that we have left and how you can get involved. As I mentioned, there are 3 sites. We are actively enrolling. And once you sign up, we will guide you through the entire process and tell you exactly what to expect. So this is how you can sign up online. We have a survey site. You go to this site, sign up for exercise, or there's a QR code on the screen, and it will take you to a sign up page where you can enter your information. That form automatically gets sent to one of us, and we will get back to you to tell you what to do next. So we really have to thank the John Ritter Foundation for Aortic Health for funding this trial, especially Meredith O'Neill and Ellen Hostetler. And we are so excited to be able to have this process of getting to know everyone who comes in for their visit. It's been a real learning experience for us. And honestly, we are impressed with everyone who's come down, their dedication, their ability to teach us so many things already, just from watching people go through the exercise protocol. It's been very eye-opening. And we're going to have a lot of data that we hope to share with the community in midsummer when we've almost completed enrollment. We'll have data on over 100 people and be able to share that with the community. So this is that is the end of my little spiel. Let me see if I can back here.
I do want to mention for everybody watching that if you are interested in learning more information, if you go to our website at aortacope.org, under the resources tab, there is a post that says research. If you click on that, all of the information, you'll be led to all of the information about this study.
Yes. So Kayla, did you want to follow up and tell them a little bit about the enrollment dates that we have coming up and how they can, what they can expect a little bit there?
Well, yes, I can. So at our study site, we typically hold our enrollment visits in person on Saturdays. So currently our next enrollment visit that we are really recruiting hard for is May 20th. That is the third Saturday in May. And then we also have 2 additional study visits in June. So on June 3rd and then on June 24th. And then our study visit in July is on July 22nd. So currently those are the study visits that we have available at our study sites. They actually do rolling enrollment visits, meaning that as they fill up, that's when they have the study visits. So they're a bit more flexible in that sense. But those are the study visits for our study site here in Houston, Texas.
Great. Thank you, Kayla.
Wonderful. Wonderful. You know, I have a million questions. I've just been shorthand. I hope I can read what I've been writing. And as we spoke beforehand, this is like political on Facebook. This is so charged. It's like a battle of wills of you've got people on one side that are extremely active. You have other people on the other side that are scared to move, that we're constantly trying to motivate to move. And then you have people fluctuating. I don't know. What am I walked. Is that good? I don't know. Can I do this? Can I not do that? And then people will say, oh, I lifted like 70 pounds. And then there's these people going, what? You lifted more than 10? And it's so daunting when I sit there in the middle of these arguments. So we're going to get into all that. But my first question after listening to all of this, after we've had numerous conversations with a doctor of pharmacy, do the drugs that we're taking, beta blockers, losartan, any of the ACE inhibitors, calcium channel, I know these names, could they be impacting our ability to work out? Because a lot of us feel sluggish. I know sometimes they help keep the heart rate down and your blood pressure down. Does that skew numbers at all for this exercise study?
Yeah, so I'm so glad that you asked that. So one of the reasons that we are doing this as a randomized study is that we want to negate some of the effects that these drugs do have. So by dividing everyone up kind of at random, we make sure that people who are taking these drugs are represented well in the exercise group. And that does have an effect. So for an example, beta blockers that are probably the most common single drug taken by everyone with an aortic problem do slow the heart rate down. And what that means is that heart rate targets that are typically used to measure the intensity of exercise don't work very well in an aortic crowd because the beta blockers will lower your peak heart rate with exercise. What we do instead, we tell people to use something called a Borg scale. And a Borg scale is basically a 1 to 10 intensity scale where 1 is the least amount of work you can imagine doing, just essentially sitting in your chair, and 10 is the hardest workout you've ever done in your life. And so you want it to be in the 4 to 6 range. That's moderate. That tends to work better than the heart rate for people who are on beta blockers, just because it's going to vary so much depending on your dose. It's really hard to come up with a number for that group.
Is that kind of similar to perceived rate of exertion?
Yes, that's exactly it is. It's a perceived exertion scale. And for each person, it's kind of their own personal, it's very constant, but it's going to differ, of course, for everyone. Your 5 is not the same as my 5.
Oh, so. No, I'm sure that it's not.
But over time, we would use that to assess their constant level of work for someone.
Yeah. Okay, so we were talking about cardiac rehab, and it's so true that you're saying that, because we just had a physical therapist on for the first time, and what we were talking about is if you're not able to get into cardiac rehab, utilizing physical therapy as in place of, basically, or you can actually use it in conjunction with, even if you are approved, because at least in cardiac rehab, they do have the ability to take your heart rate before, during, after, and your blood pressure, and check out the PREs and see how you're feeling based upon the numbers. Because again, what you say you feel is so different. It equals to what the number is, but everybody is different. So thoughts about physical therapy in relationship to exercise?
Yes, yes, I think that's a great point because it's really the supervision aspect that you need, and physical therapy can get you that. It's the reason why we insist on doing the one in-person visit before you start the home exercise program in the trial, because we really want to watch people in person doing the exercises to make sure their technique is good, they're not hurting themselves, their blood pressure isn't too high. All of those things are very hard to assess remotely. And so cardiac rehab is the ultimate because you get that done day after day for weeks. Obviously, a lot of people can't get that. So, physical therapy is a great alternative. And I do think one of the issues that we have is that a lot of physical therapists are not comfortable working with people with aortic dissections. I get scared calls. In fact, from Austin, last week, I got a physical therapist who was terrified because she was working with a vascular EDS patient and had 3 dissections, and she didn't want to do any work with this patient. She was just afraid to touch the patient. So there is a lot of, I think there's a lot of education that needs to happen, and it works if they're very communicative. So that, in that case, we had a great conversation. I told her about our data. We discussed a rational plan to start, and then she was going to reassess. So it worked out. But sometimes, if you don't get that communication, very little can go right, as I find. I think that it actually makes patients more anxious in that situation, and it can be less effective. So it really, you really have to find the right therapist, and I'm afraid, that's hard in our case. At least it's been hard to find.
Right, exactly. So just so I understand, in your study, because there is no constant, I mean, every single patient that has aortic disease, we're all a little different. There's so many different nuances. Some have comorbidities, some don't. We have underlying other diseases and issues. So is the goal to ultimately figure out a range, a target range? Okay, so if you have a thoracic aneurysm, well, you're not studying people with aneurysms, but let's say you had a dissection and you have an aneurysm. Are we thinking, well, this is the targeted heart rate we think everybody who's had this or has this should stay within, or this is where your peak performance blood pressure should be and your recovery should be? Is it that, or is it more just generally what we've developed and what we've realized is you can exercise? Because then we're back to the what does that mean again for everybody? How do you define exercise is the problem that's so charged?
Yeah. So I think it's really to first of all, we want to demonstrate with this particular trial in a very rigorous way that exercise is safe and that it can also have immediate benefits in terms of mental health and lowering blood pressure. So that is the goal for our short-term study. But you're right, we want ultimately to be able to issue exercise prescriptions for patients with aortic disease, the same way we would prescribe a beta blocker and then check your heart rate and titrate the dose based on your individual response to the beta blocker. Well, exercise is going to be the same way. Everyone's exercise prescription will be based on their individual situation. So it could be based on the type of aortic disease you have, how stable it is, your blood pressure status, but it would require an intimate one-on-one kind of consult with the doctor who knows your situation, and then be able to feed back on it, over time. So to reassess you, make sure you're doing okay, getting feedback about the exercises and about how your condition is changing. That is really the goal in the long term and how to bring this to clinical practice.
Which would be
the first
amazing.
step is just to show that we can get there,
Yeah, that would be amazing because again, the definition of exercise is so varied because I've met people in the community who have run Spartan races, who do all types of obstacle courses, triathlons, marathons, 30-mile bike races. They're still bench pressing, they're still weightlifting. They say they're breathing out, so therefore any weight should be okay. It runs the gamut all the way down to just people who take a daily walk with their dog and they're really happy with that. So, or people that are doing yoga, but some people don't like certain positions because the blood rushes to their head. It's like, I don't even, or swimming. We're getting ready to have a whole article about the benefits of swimming. And yet some people in 5 feet of water can feel pressure in their chest. So, okay, well, maybe swimming's not comfortable. It's just flipping through these cards of what is exercise. So if you had to give it at its basic, because we're always motivating people just to move based upon their doctor's recommendations, what would just basic exercise mean to you?
Yeah, basic exercise is purposeful movement that you do that provides some exertion, and that can be anything from walking all the way up to running a race. It's whatever feels like exertion to you. And what I tell people is that almost any exercise can be almost anything to our patients, because they come from so many different activity levels. Someone who's recently experienced a dissection may not have been active at all, may not even have been walking, for months at a time. And so for them, even the thought of doing an exercise could be intimidating. And so we wanted to make this, very as basic as possible so that anybody could get in and start working with it. And of course, you can take it as far as you want. The goal here, one of the things that we're tracking over the 12 months is improvement. We want to see people, going longer, doing more reps, feeling more confident to engage in longer exercise, and then reporting that back to us. It's one of the reasons we check in with them during the exercise sessions.
I would assume you have patients in the study that have VEDs, that have low EDs, that have Marfan's or Turner, or a variety of mutations thereof. What is the percentage of people you find that you're accepting that have a known condition? Because then the rest of us, we know we don't. So how does that balance?
That's a good question, Kayla. I don't know that off the top of my head. Do we know?
No,
yeah, I can't tell you exactly what that number is because we're still recruiting, but I can say, like, from our patients, a substantial number are diagnosed with known gene mutations, and so and many have a family history. So that has definitely played a role in their reluctance to exercise in many cases, because they may have known a relative who had a dissection, and there are all sorts of anecdotes about whether, as I said, whether specific activities cause dissections, and if they've only didn't do that one thing, they wouldn't have dissected. You hear that a lot. We think that, in most cases, that's very hard to prove. And when we actually look at the data, there's actually very little data implicating specific activities with dissections. Most dissections seemingly occur without any obvious inciting activity before them.
Okay. I want to check in to see if we have any questions specifically about this before we get into any other studies and our regular Ask a Doctor. So I'm just going to check to see, do we have any questions or comments about this section so far?
So far, we just have regular chat in the chat. Hi, Rob.
Lots of chat.
Hi, Ryan.
Okay, we've got a lot of people just chatting away while we're talking. That's what would happen if we were in a room together. They'd be like, so that's fine. Okay. So as far as this study, we now know how people can get in touch with you. We're going to have information here on this live. I want to ask you this. Let's get down to brass tacks. What kind of exercises are people doing? Because let's not even talk about myself and my own exercise issues, because every time I tried with cardiac rehab and I tried to increase it, something would happen. I'd go have a TIA, or I'd have complex migraines and I have issues, and then I'd be right back down at the bottom again. So years later, we're talking, I was in PT for 8 years, the better half of 8 years. I would have to stop, and then I'd go back just for stamina, just for stretching. As soon as you put me on that treadmill, or my body says, absolutely not, I'm going to throw away me. And okay, so I'm learning to live with that. I'm making adjustments. I'm realizing for me that a good day is holding a paddle and kicking behind me in the pool, and then I go take a little nap. And I can't do it the next day, but that's just me. I'm figuring out how my body's responding to my set of circumstances and my situation. What are you having everybody do so that people that are nervous get an idea upfront what they're doing?
Kayla, why don't you tell them about our exercise circuit?
Yeah, sure. So we primarily have the participants do moderate intensity exercises, which are also classified as isometric. So they do bicep curls, they do wall sits, they do 6-inch leg raises, they do a brisk walk on a treadmill with an incline, they do a stationary bike, and then also a hand grip. And so, yeah, that is basically the entire circuit that we have them complete.
I would totally sit down on the floor and say, I am not doing a wall sit, or I would end up sliding on the floor. So
yeah, so that's one of the reasons we observe people at the beginning, because sometimes they have to modify, And that's
Right.
perfectly fine. If, if they do a wall sit at 45 degrees to start out with,
Okay.
that's a wall sit. I mean, it's a start. And then, of course, we can track that. Maybe they go more vertical
Sure.
over time.
Yeah.
But yeah, and they start with 2 minutes with each exercise, and they
Sounds
can
like
build up
torture.
from there.
Sounds like
So-
torture to me. But I am curious. So you are there to make sure that people, as they're doing this wall sit, obviously, because when you say isometric, again, the politicalness of this in the community, no, I'm not supposed to do it. So they're
Yeah.
learning how to actually do this and breathe properly, and
That's
nobody's
right.
straining or holding their breath.
That's right. And we want them, like I said, we gauge their activity response using the Borg scale, so we know we can keep it moderate. And we can also modify, so like 1 leg or 2 for the leg raise, or
Okay.
different weights with the dumbbells and on the bicep curls. And of course, we measure their grip strength. The grip strength is something that's actually very predictive in terms of your lifespan. And if you can increase your grip strength, you can actually increase your lifespan. It's like a magical power. So
I'm writing that down and really.
Grip strength is one of the things we're tracking during the trial because we want people to have less fragility. Fragility
Very
just is a
interesting.
general medical term for being vulnerable to physical injury. And if
Okay.
you're stronger, the idea is that you can be more resilient. And therefore, if you do have problems in the future, you're less likely to experience prolonged disability from them.
I've never heard of that. So, I'm walking around the house. This is going to be me. I'm going to get a water bottle. I'm going to go. We have stress balls. I'm going to just walk around the house now and start squishing my stress balls. Okay. All right. Outside of this study, what other studies do you have going on right now that we should know about?
Yeah. So we do a lot of work with bicuspid aortic valve, and we do genetics of bicuspid aortic valve. So that study is actually finishing up, and we're not accepting any more applications for that study. Maybe in the future, but for right now, we're doing the analysis on that part. We are recruiting for studies about Turner syndrome. So Turner syndrome folks do have a lot of problems like bicuspid aortic valve and aneurysms. And we're doing some studies of stem cells, so people can donate their blood for stem cells. And then we are testing those in a laboratory setting to find out what causes bicuspid aortic valve, with the idea that we will develop new drug therapies. And that is in progress and will be going on for the next year.
Okay, so I will get that information from Kayla.
Yes.
We will have that up on our website in addition to the exercise study. So let me just ask you, because I don't really know, bicuspid valve. I think a lot of us think it's a one-off thing. I mean, I know my own family. I've only seen one of my cousins have a bicuspid valve. Their children don't have it. Their parents didn't have it. She had the bicuspid valve. She developed an aneurysm, had her scheduled surgery. She's off living her life. No fuss, no muss. Is it hereditary? Is the potential there? Do we all know for sure? Is that something we can say with certainty? There's a good chance it could happen. I mean, I suppose there's a good chance anything can happen, but what's the answer in that?
The answer is that it is definitely hereditary.
Okay.
So about 10% of people with bicuspid valves will have at least one relative who does have a bicuspid valve. And the current recommendations are, if you have a bicuspid valve, all of your first degree relatives, that is mom, dad, siblings, kids, should have an echocardiogram to get tested.
Okay, so let me ask you, if they all come back negative, are they at any kind of risk for issues with their aorta being just separate from that?
Yes.
Or does aortic issue, so they are at risk for aortic?
There is some evidence that patients can have aneurysms in the same family who do not have a bicuspid valve.
Wow.
So it can affect different people in different ways. And it's not, so just because you don't have one does not mean you will not be at risk to develop an aneurysm later in life.
So this comes back to the whole think aorta, think family. If you've had a family member who has a bicuspid valve, the immediate family members should be tested to see if they too have the same type of valve. And of course, it could be I forget what it could be 4, it could be 1 cusp, 4 cups, it could be anything outside of the 3. If they don't have that, that does not mean they're out of the woods for developing an aneurysm. So I wonder how many primary care physicians actually know this. So this is the first I've heard of this, blowing my mind, but this is where advocating for yourself and saying, okay, now I have a baseline in my aorta, maybe we come back in 3 to 5 years and let's just keep checking it. And that's where being monitored throughout your life is really important.
Yes, exactly. And it is true that it is very few people are getting screened, we're trying to spread the word. We do that in our clinic. If we do see someone, we make sure that they spread the word to their relatives. But it is an uphill battle. And if you are able to get that message out to the community, I think it could make a huge difference. As you know, there are really no symptoms with this condition until you have a very, a large aneurysm or dissection and need to have surgery.
Right, exactly. Well, I'm going to be on that mission. We're all over that, I can tell you right away. All right, so now that we've heard about your other research studies, we're going to start the whole Ask a Doctor portion, but we are not going to go until 9:30 like we usually do. I'm not going to keep you on here with me this late. So let's talk a little bit. Issues with exercising in the heat. We talk about it when it comes to winter time. Let's talk about the temperature extremes. What actually causes issues for aortic disease patients when we have such extreme temperature changes?
Right. So actually in aortic dissection, the thing that is most dangerous is cold weather. More dissections happen in January and February than in any other month of the year. And the reason for that, in large part, is due to the winter climate. And so we know that cold air, breathing in cold air, can have a direct effect on your blood vessels and your heart. It causes changes in the way the heart squeezes. It can raise your blood pressure. And if it happens suddenly, the thought is that can predispose to aortic dissections. But it also, we know that, heart attacks are more common during those months too. So it has other effects on different blood vessels.
Okay.
But
so
in terms of heat, there isn't a lot of data. What we think is that if people are taking medications for aortic disease, they're more susceptible to heat stroke. The reason why is that their blood pressure might become lower more quickly. If they get dehydrated, they're more susceptible to feeling faint or lightheaded. And so I always tell my patients, you've got to maintain hydration during the summer months. It's so important. You're going to be outside because people are not used to doing that necessarily.
Right. Okay, next question. And Josh, let us know if we have anybody else that's chiming in with questions.
Ryan has a question.
Oh, okay. Go ahead.
He says, okay, legit question for my VEDS community. Are there any special precautions taken for those with VEDS?
Special precautions for those with what?
Vascular
VEDS.
Ellis Dandros.
VEDS. Okay. Special exercise precautions. Yes, it can depend on where your dissection is. So if people with VEDS often have neck dissections and groin dissections. Those are two very common places. Neck dissections can pose a risk if you're doing a lot of twisty movements with your neck. Even having a chiropractor adjust your neck, we've had patients dissect. So we do recommend avoiding physical manipulation of the neck in those cases, because, especially if you already have a dissection, because you know that the vessels are vulnerable. In terms of other kinds of issues related to VEDS, there really aren't any restrictions based solely on having VEDS. It's really based on the pattern of where your aorta is affected that determines it.
Okay. Seasonal allergies. We are going to get into the throw of it right now, right? How can we combat that, given potential blood pressure issues with certain antihistamines and medications? What's the best way that we can work around that?
Yeah, so I mean, there are fortunately, there are a lot of new treatments for allergies that are they're not as bad. Some of the non-sedating antihistamines, are the newer ones on the market. There are many different brands. They're all pretty safe in terms of your blood pressure. They don't tend to raise blood pressure like the old ones did. And of course, you can be more active with them. They don't have the same sedation side effect either. The other thing is, oral nasal sprays can be very effective, and they stay in the nose, so it's not a pill that you take. So if you combine those two, most people can find some relief. I think that allergies are definitely getting worse. It seems like it might be due to climate change, but there might be more pollen. That's one theory. Or the summers are just getting longer and things aren't dying in the winter. I guess that's another way to look at it.
That's
But
another
for
theory.
sure, I have allergies and I do those things. I think a lot of people are finding some success with that. But it should be safe, you know, and not interfere with your aortic disease medications.
Okay. Why do some people complain that they feel a lot of pressure when they swim, when they get towards the deep end
Pressure in their chest.
in their chest?
I think, you know, it depends on your the way that the kind of exercise you're doing in the water. So what I would say is if you're feeling that pressure, maybe try a different stroke. One thing that might help is a different position in the water, like a backstroke, instead of, you know, using your arms a lot. Maybe get that chest above the water. And I feel like very relaxed when I'm backstroking because you feel like you're being supported instead of having the water on your chest. So if you're really searching for alternatives, there are different positions you could try. So backstroke or side stroke, for instance, instead of a more traditional stroke where you're facing the water. That can sometimes also feel better psychologically.
I agree. And I was so excited when I saw this question because I realized, okay, I'm not the only person. When I am doing traditional breaststroke or what have you, I feel that pressure, especially if I'm just hanging out in the deep end. But as soon as I did change to backstroke, it's not only relaxing because you can just open your eyes and relax and just look around at the clouds or whatever, but immediately I didn't feel the pressure because I know my chest was out. And also, especially if you're new into recovery and this is your first summer, you might find all the twisty motion and using your arms uncomfortable in your sternum. Whereas when you're on your back, you don't have to do all that twisting. So right on the money there. Okay. Why can't we scuba dive? I hear people that want to scuba dive. Why
I've had
they,
a lot
or
of,
can't they?
I get that one quite a bit.
Yeah.
The answer is, you know, there is some theoretical concern, particularly if you're doing deep dives, about the risk of the pressure gradient and the potential changes that we know occur in the blood vessels. No one has ever looked at this. There's no scientific data. So another trial, we could recruit a bunch of scuba diving volunteers. We could have some control data first, and then we can get some of our aortic volunteers to do it. I think it would be fascinating, actually. And you know, if we had enough motivation, I think we can make it happen.
I'm just
we
thinking
need
that
data. We need data for that.
yeah, but I would just think, isn't it because you're not really depressurized? I don't know. Like, how does all the pressure when you're going deeper down into the water? It's opposite of being in a plane. I mean, I don't know. I've just become very much like, why risk it? Like, do you want to jump out of a plane? Is that the next question? I don't know. Some people have different ideas on what they find to be very fun, especially with this condition. So there really isn't any
well,
data
I mean,
to support
I can understand the you know, people who are operating or supervising these activities would be extremely concerned because there's so little you can do to rescue someone in that situation in a timely fashion.
Yeah, exactly. So can you explain, this is a big one, we get this all the time, why if somebody was diagnosed with a root aneurysm, why do they have to wait till we get closer to 5 or 5.5 if they don't have a known connective tissue disorder or a known syndrome? Why are we just sitting here and waiting?
Well, I think it's a personal decision that you make with your doctor. So if people are not able to live with that uncertainty and anxiety, then it's a perfectly legitimate reason to have the surgery, as long as you understand that the surgery is not zero risk. If you say, I accept the risk, and you sign the form, then you are making an informed decision. And that is your right to, as a patient, you can ask that question. We do perform elective surgeries regardless of the aortic diameter for many patients. And you know, with good outcomes. It's always an option to ask your doctor.
I mean, it sounds like because they are risky in general and they are not easy surgeries in general, that as long as you're holding your own with your symptoms, if you're symptomatic, if let's say you're going to have your valve replaced, then wait until it's absolutely necessary, because it's still going to be the same surgery whether you do it when it's more diseased or large, smaller, larger, it's still the same surgery. It's not like it's a more intricate surgery. So why not push it until you really have to because of the risk portion of it? Does
Yes,
that sound about right?
but other people say, look, if I feel like the surgery is inevitable, I want to get it done now. I don't want to wait. And
Right.
I respect that too. Everyone has a slightly different, very personal reason for either pursuing it right away or maybe postponing it. And it's really up to us to listen to them and decide what, how can we how can we respect their values and help them make the decision.
Right. And let them have the most quality of life, because
Yeah.
because so many people, and I'm so surprised that you're saying this answer, because, my doctor is emphatically like, no, you are at 4.6 with a moderate valve insufficiency. And I dissected on the ascending. So this is at my root. He's like, no, we're not ready yet. You are not going to die with these symptoms. And I'm just like, okay. So I can't breathe when I walk upstairs. That's fine. Okay. I just will avoid stairs. And and I'm part of this watch and wait crowd now. And I can see the anxiety. I mean, believe me, I'm not looking to have surgery. And I had to have to fit it into my very busy schedule, because it's complete disruption. It's a complete total upheaval of 12 more weeks.
And it is important to tell people, what you're signing up for here is a major divot in your life. It's going to take you weeks, if not months, to recover. But I have patients who've been in the ER every month for 6 months in a row. That's not a good way to live either.
No.
If you feel like, that you cannot live with that, then maybe it is worth at least considering doing it early. And we always, we're always willing to listen to someone who has another viewpoint, because that really tells us what is important and what we should be focusing on.
And you just said ER, which made me think of another question. So there are many people in the community who find out they have to have shoulder surgery or knee replacement surgery or any kind of sinus surgery, just name it. And they're very scared about the idea of having surgery. So can you give something more definitive? Of course, we don't know everybody's cases. Is it okay to have random other surgeries or have a colonoscopy or whatever the case is after you've had a dissection, or if you're waiting with an aneurysm?
Absolutely. And it is so important to do your routine maintenance screening exams, because you can get colon cancer, you can still get breast cancer. So all of those screening exams, I absolutely encourage everyone to do. In addition, the surgeries that are not considered major surgeries, which is not like an internal body cavity or a major organ or a blood vessel, those are generally very safe for people who've had dissections and are stable. Now, obviously, you want to go to your doctor before any elective procedure and make sure that you are in fact stable. And if that's the case, we have very good outcomes, and we can write a letter and state all this to your doctors to make sure that you get the procedure that you need.
Because they get nervous too when they see us. Like, oh, I'm not sure if I want to touch you. They do.
Well, I mean, the key is to tell them, this is the diagnosis. This is how we're managing it. Here's what you do on the day of the surgery. Call me if there's this issue, and that reassures everybody, because they know there's a plan in place and that this is all expected and they're being followed by someone. That usually alleviates any kind of delay from the other side.
Gosh, because when they get nervous, then we sit there and we think, why are you nervous? Should I be nervous that I'm sitting here? Am I on borrowed time? It's just crazy how they can end up inadvertently making us feel. Okay, any issues traveling into a location that has high altitude? What if somebody wants a vacation and they're going to go up high in Colorado? I know people live at those altitudes with a dissection and aneurysm because people live there. But do we need to worry about what we're going to feel coming from a lower going to higher? That's the first question.
Okay. Yes. So after dissection in particular, your body takes a long time to recover, and you may feel fine at low altitudes, but you must give yourself at least 24 hours at a high altitude to acclimate before you start exercising, because your body will take longer to acclimate. And if you push yourself too hard, you can, raise your blood pressure and put your body in under strain. Those sorts of things are the situations we're trying to avoid. So I tell people, make sure you acclimate and take things slowly at first until you are sure that you are not, pushing it too far. Most people are able to do it just fine with those, within those limits.
Okay. So is it recommended, or do you think it makes a difference? Because a lot of those places will offer little dosages of oxygen? Does it make sense to have that on the ready in case you start developing any kind of altitude sickness? Does that help combat it?
Yeah, I mean, you can take medication for altitude sickness. Some people take that with them. It's fairly, I don't generally prescribe that, but I've had people ask for it. Oxygen is generally not necessary unless you're going to Mount Everest. But
Right.
I mean, most of the time, it's not so great that you need oxygen. If you need
Okay.
oxygen in those levels, you have other problems.
Right,
You
you
should
should
probably
coming
be
down.
seeing your doctor before you go on the trip.
Exactly. Come down wherever you are.
Right.
So talking about that, we always get this question. I mean, I find them funny now because I'm 8 years out, but one of the first questions was, when you have a cold, can you sneeze? I mean, everybody worries about the exact same thing. It's just like a woman when they find out they're pregnant, they're like, maybe I shouldn't sneeze. We just think we're going
Right.
to sneeze a baby out. So obviously, when you have a cold, sneezing isn't going to impact your aorta or your surgery. I mean, it's just going to be uncomfortable if you had surgery.
Yes,
You're
that's
fine.
right. I mean, you have to hold the pillow on your chest, obviously, if you have an incision. But other than that, it's not going to cause your aorta to rip if you sneeze.
Right. So then the second question always is, can I fly? People always want to know if they can fly and go take a vacation. So other than the people that are within their first 3 months, and you're still in recovery, what would you say to them?
If you're out of the first 3 months and you're doing well, you can fly. I mean, the main things that affect people when they're flying are lung issues, and those can happen right after surgery. You can have a deflated lung or you can have fluid around the lungs. In that case, you probably want to get checked out before you get on the airplane. But if you've been doing fine, you finished your rehab, you're doing your daily activities, you should have no trouble whatsoever flying.
And we do try to tell people, look, if it's your first time traveling, like I know a lot of people like to do a little bit of research. Well, I'm going to go to another state. Where would there be the hospital that I might want to go to? Or if you're going to another country, they shouldn't hinder you, but it's something to maybe think about because not every country on this planet has easy access to CT scans or has easy access to just care for patients like us in general. So, in the middle of Egypt might not be the greatest place. I don't know. Or in the middle of, I don't know, name a place that doesn't have access. I can't think right now, which is just something you want to give a little bit of consideration to.
Absolutely. I
in
mean,
the jungle.
certainly my patients have asked me for more itinerary. They actually send me their itineraries and they ask me for the hospitals along the way, which has really enabled me to learn a lot of geography, to be honest. So I'm happy. I kind of wish I would go with them, but other than that, no, it's actually a very common question. And the other thing we talk about a lot is evacuation insurance.
Okay.
So in some cases, when people are going to remote areas, you can buy evacuation insurance. It can be extremely difficult. Like if you're on a cruise, it can be extremely difficult to sometimes get those services. So it is something to consider. I don't think it should stop people from going on vacation. However, if you think about it, the risks are so low that on any given day or set of days, something is going to happen. That a vacation is just a drop in the ocean. There's really nothing that you should worry about in that regard.
Right. Okay. Another question real quick. What's the difference between warfarin, Coumadin, Plavix, and any others that I'm missing?
Right. So warfarin is or Coumadin, they're the same drug and generally two different names based on the company or the generic version. And they're both, they're vitamin K antagonists. They work in the liver, and they're used by people with mechanical heart valves of all kinds, mostly aortic valves for this group, but also mitral valves. And they work by, thinning or increasing a number called the INR. So you have a test, you usually have to be tested at least once a month or more often, depending on how long you've been on it. So it is a bit of a pain, but you can do them at home now. And we can send your numbers directly to the doctor's office. So that's been a game changer for a lot of folks. Plavix and aspirin are the two that are used for people who've had strokes or heart attacks. Generally not so much, sometimes a little bit after you've had aortic surgery if you have another type of valve for at least a few months. But those are worked by thinning a different part of the blood called the platelets. and they take about a week to work and a week to come off. So if you have, the main thing to know about that is if you're having surgery, your doctor usually asks you to stop one of those two or both a week before your surgery. They don't tend to require any sort of blood tests or anything while you're on them.
Okay, and then Eliquis is another one, I think.
Yes, right? Yes. So Eliquis and Xarelto are other medications. They work differently, but they're more like Coumadin than aspirin or Plavix in that they thin the blood, kind of like Coumadin, but they don't require monitoring with a test, and they're much easier to take. You don't have to adjust your dose or anything like that. Those are really popular, and they're used for a lot of things, but they're not used for heart valves. So a lot of times, our patients can't really take them. They're not eligible, at least not yet. Maybe in the future.
Okay. All right. Let me check in and see if we have any other questions from the community.
We have a couple here from Deb Jolly Workaholic.
That's not her last name, by the way, but that's just what he calls her. Okay, go ahead.
How often should relatives be tested that have family history but a normal valve?
Okay, great. So this is for the bicuspid aortic valve question?
Yes, sir.
Yes. So bicuspid aortic valve is present from birth. So if you don't have the bicuspid valve on the first scan, you won't have it ever. It's not something that you get later in life. The main thing would be to test for an aneurysm. So if someone does have a bicuspid valve and they have a normal aorta at the first scan, that doesn't mean that they can't develop an aneurysm later in life. And those people will need to be followed throughout their lives because they can develop an aneurysm later. Typically, by their 40s, you would see some sign of it, but so if they're very young, it can be completely normal.
And if they don't have a bicuspid valve, should they still be monitored to check their aorta?
Yeah, so that part we don't know yet because the incidence of that, while I said it exists, it's not known exactly how frequent that is.
Okay.
So we do find individuals with aneurysms and normal valves in those families, but we don't know how long we need to monitor them if they don't have a bicuspid valve. That's something that we're trying to figure out.
Okay.
Okay, and follow-up question there is, what type of diagnostic tests should be used for relatives of BAV patients that do not have BAV?
Yes. So in that case, the diagnostic test of choice would still be an echocardiogram, at least for screening, because you can not only diagnose whether or not they have the BAV, but you can see the ascending aorta, which is the part near the heart that is most likely to be an aneurysm in someone with BAV. And so it is the most widely available, cheapest screening test you can get that rules out both conditions.
Okay,
Perfect.
and we have some more just coming into the info box here. My doctor wants me to take medicine such as Ozempic, thinks it will be helpful to my heart with some weight loss, but also keeping A1C low. It is not high at the moment. Can you offer any thoughts?
Yeah, so I mean, we are increasingly seeing patients who are on Ozempic already when they come into the office. I haven't seen any evidence that it interacts with common blood pressure medications, for instance, that are used in our patients, and they seem to tolerate it very well. Now, it doesn't work quite as well as advertised in everyone. So there's some people who don't lose a lot of weight, but it doesn't seem to be harmful. So I am generally in favor of weight loss. I think that if you are overweight, it can definitely pose a risk for several reasons. It can raise your blood pressure. It can also make it harder on your joints. If you move, you can get more pain, and that can prevent you from exercising. And we all know that that should be a goal to stay active. So all of those things kind of limit your ability to live a healthy life. And that's why I do encourage weight loss as part of our treatment goal. And Ozempic is effective for some people, but not for everyone. There are other options that you could and probably should look at if it's not working.
Okay. You answered this question earlier, but I want to make sure the user hears that the question was asked. I have read about many people who never make it to the 5-centimeter mark for surgery and had a dissection well before. Is this common?
Yes. About half of people who have dissections below the size threshold that doctors recommend to have elective surgery to prevent dissections. And this is kind of a paradox that we don't understand. We do know in some cases that a gene mutation if it's in the family, predisposes to having a dissection at a normal or very slightly enlarged diameter. And we will tell people that, but the vast majority of time we don't understand it. So this is why, if you have a dissection, it's critical, and we've been telling the surgeons this, to report the size of the aorta at the time of dissection. It is so critical because it can have implications for other people in the family. If we can tell that from the operative report, and then we can counsel the relatives who might be affected, say, and that becomes the diameter that we recommend them to have surgery below, you know? So if your relative dissected at 4.6 and you're at 4.2, it then makes more sense, you know, to have an earlier cutoff, and we would advise you accordingly. Unfortunately, you know, until recently, at least, that was not the standard of care, and we could not get those numbers. So hopefully, you know, and we are trying to re-educate the community so that we can give people more accurate information.
And what if you're someone who had a dissection and you know what the number is, and now you have an aneurysm and you know that that number is now the same as the prior number?
Well, in that case, I would say, you know, it's probably reasonable to, you know, have that conversation. Like,
That's what I say.
Well, what are we doing here?
Right. I say it every time. I sit there and I say, I don't understand. If I dissected at this number and now I have an aneurysm at that number, we just waiting and we're just playing the Russian roulette. Like, what are we doing? Why wouldn't we do it? So this is giving me, so for me, this is a prime example of what we tell people. This is giving me a new way of presenting my question to my own doctor to say, what are we doing here? Why am I hearing this? Why are we,
right.
I feel like I'm pushing, and my doctor doesn't feel like we're pushing the envelope yet. But I feel like we've already gone past that line. And why are we keep moving the goalposts? Let's just get it over with when my schedule allows it. But this is good because now I have more dialogue.
It is truly complicated because let's say the first person in the family to have a dissection was probably not taking the medications, right? They probably didn't know necessarily. And the second person would be on all of those medications. So how does that affect the threshold? We don't know. But it could provide a safety margin of some that could be reassuring, and maybe that's what your doctor's relying on. But like I said, we don't know, and it probably would be different for different families. So I don't think you can assume that, but that's part of the assumption that I'm sure people make.
We need to just sit down and have a conversation. I like that.
Okay, just
all right,
a
Josh.
few more in this email chain here. I cannot even be seen by a local surgeon until I establish a 5 centimeter. Advice on how to live life, exercise, how high should my heart rate be, anxiety I've never had, how do I do this now, and a specific diet should I follow?
Okay, that's a lot of advice. What I would say, you know, for the most important thing I think to address here is anxiety. So first of all, if you are having trouble finding a doctor who it is important to get early treatment because that is potentially life-saving. Like we said, there is no, you know, the number is for a large population. So the reason the numbers came around is because they looked at thousands of people who had dissections and they said on average, how large were their aortas? You're not a number, you're an individual. Everyone is different, and in your family, that is really a meaningless cutoff because it really has to do with your underlying biology, what's going on there. It's different. So I would say looking at that is short-sighted, and you should find a clinician that feels the same way and treats you regardless of what your number is. The second thing is that, you know, waiting and dealing with the anxiety is crippling for many people, and it's okay to get help for that. If you feel like that is preventing you from doing things and living your life, you should ask for help. And there are therapists that are really good at helping our patients. In fact, I rely on them all the time. And I can tell you that it's really important because we would not be able to take care of our patients without constant support like that from mental health professionals. It's an extreme burden to live with. And so many people need that help. And it also greatly impacts their ability to adhere to medical therapy and other parts of a healthy lifestyle. It's all connected.
Okay, I agree with all that. Do ascending aortic aneurysms ever shrink with the use of losartan?
No.
I would like for you to at least say that they never shrink, because I think that would be
They
kind of
never
weird.
shrink, period. And that's because it's not the way the aorta works. It doesn't shrink, it will stop growing. And sometimes, like if it's a young person and their body grows and the aorta stays the same size, people will say that it shrinks, but it actually is just in relative terms. So that's confusing to a lot of people. But no, the aorta doesn't physically shrink over time. We just look at the growth rate and see if it's slowing down. It's not growing quite as fast. Then we know the medicine is working.
Okay. The last one here in this chain is, what are symptoms do I look for with a bicuspid valve with an ascending aortic aneurysm in a dissection situation?
The bicuspid aortic valve symptoms are usually related to either stenosis, which is stickiness of the valve opening, or leakiness, regurgitation, which is blood leaking back into the heart when the valve is closed. Either of those things can cause irritation of the heart muscle. When that happens, you can get extra beats, a lot of times skipped beats or feeling like rapid heartbeats. That's a sign that your heart is under stress, and you should get it checked immediately if that's a new symptom for you. The other thing would be getting short of breath if you're doing normal daily activities that you used to do without any problem, like walking up a flight of stairs or going a block. All of a sudden you have to stop and rest. That would be another sign that things are changing with your heart and you should get it checked out. So with the bicuspid valve in general, that's what we would tell patients to look for.
Okay, thank you. We have some questions here in the chat as well. Deb asks, and I'm going to ruin this word, does spironolactone help with diastolic?
That's perfect.
Yay! Help with diastolic heart failure related to fluid retention?
Yes, so spironolactone is used to treat people with diastolic heart failure, which is when your heart doesn't relax, it gets very stiff, and the pressure builds up inside it, and sometimes it can make it hard to breathe. It helps to relax the heart over time. It does not necessarily, it doesn't work great. There are some other treatments that are like it. We don't have a great treatment for that kind of heart failure, but it is common in people with aortic stenosis and other valve problems like we were just talking about. Over time, they can develop diastolic heart failure, and they need these kinds of treatments to keep their hearts working and being able to do normal activities.
Okay. Christina's question here is, have things changed medically? I received an IVC filter. No one told me I needed it removed within 6 months. Can I still get it removed 9 years later?
Probably not, because the IVC filter will have grown into the wall of the IVC, and the only way to remove it is with a big surgery. So typically, after time, it becomes extremely hard to remove, and your body kind of grows around it. This is true for a lot of stents or filters that are put into blood vessels. They're almost impossible to remove after a period of time. And that's by design, really, because we don't want them coming loose and going different places in your body. It generally doesn't cause a problem. If you're not symptomatic, I wouldn't worry about it. It's not something that needs to come out.
Okay. And then we have another one from an email here. I have multiple aneurysms in 3 different arteries. The 2 major ones are in the thoracic area, one ascending and the other descending. During my last exam, I was told I wouldn't need to be scanned again for 2 years since they are stable. Is that normal?
It can be. I mean, it depends on how long they've been following you, but if they've been doing a series of scans over time and they're stable, it's reasonable to go out to 2 years or sometimes even 3 years. We definitely have folks that we see every couple of years and they're doing fine. If you see a change, of course, you should go back to doing it more frequently. That's the catch. You can't just keep doing it every 2 years without regard for the changes that occur.
Okay, thank you. That catches the chat up and the email so far.
Okay, so as we are rounding past 7:30, I'm going to put a call out there for anybody who has any other final questions to put them into either info@aortacope.org or put them in the comment section below as I ask my last question. Okay. the funny thing is before I ask this question, is that it just left my head like that. And that happens, right? It happens all the
Yeah,
time.
it's been a long
Oh
time,
my
so I
gosh.
understand.
It's like that pump head thing. It just never leaves. Now I just blame everything on that and not at all remotely on age. So let's talk a little bit more about um, blood pressure in general. And people are now starting to ask about watches. I'm starting to hear a lot more watches that are offering this ability to take blood pressure. I know that's kind of why I bought my Samsung Galaxy. It was supposed to have it. The FDA won't approve it. They're approving some.
Yes.
But I think my general thought is, and tell me if I'm wrong, is the farther away from like the top of your arm, it could be less accurate. I still think that arm cuffs are probably the best way to do it as long as you're doing it correctly. What are your thoughts on taking your blood pressure and the best device?
Yes. So if you're using a cuff, it should be an arm cuff and not a wrist cuff. Wrist cuffs are not reliable for many people, particularly if you've had aortic surgery. They're just not reliable. Don't use them. And arm cuffs, it's really important to realize that most of the ones you buy in the drugstore, they're only designed to last a couple of years. So you do have to replace your device. It's not worth getting them repaired. It would cost more to get them repaired. So it's better just to buy another one and make sure that you calibrate it by taking it to your doctor's office. I see that a lot, that sometimes they're 20 millimeters of mercury off. I had one today like that. And so it is important to get to know you're getting good information, reliable information. In terms of the watches, the FDA is set to approve some, like you mentioned, but the ones that seem to work the best are the ones that you calibrate against an arm cuff.
Okay.
So the ones that are standalone, I wouldn't trust those because you need an independent source of information, once again, to make sure you're getting good data. But if you can calibrate it against an arm cuff and do that, I think you're supposed to do it every 2 weeks or so. Those actually seemed like a very good alternative, and we're actually looking at them for our next trial.
Oh,
because
interesting.
it'll be a lot easier for people to check their pressures at home and give us continuous readings. And I'm really interested to see how that plays out in our community because I know a lot of people are keen to use these. We haven't been seeing a whole lot of them yet, but I expect in the next 6 months, that'll be a game changer for a lot of people.
Well, and it's interesting too, because when I got this watch, a lot of the heart rate rhythms, they were buzzing and saying that I was having AFib. So I would quickly send that EKG screenshot to my doctor. Like I send it to her anytime, day or night. And she's like, no, that's not AFib.
Right.
It's SVT or it's this. But I mean, I know that the watch is not going to tell me if it's a PVC or whatever the case is, but at least it was picking up something, although not anything I needed to worry about. It also seemed to be off at my nighttime sleeping oxygen levels. It was saying I was dipping into like the low 80s, mid 80s over and
Right.
over and over again. So I went for a sleep study, which said, no, you're not. So then I feel
Right.
like it's returning my watch. Like I don't want to put so much faith into some of these things, even though I was still having symptoms. But I do personally, I kind of liked the Cardia that they come out with. If you feel you need to have your EKG monitoring system, that Cardia is a great little device to just put your thumbs on and it whoop, zaps your EKG right off. Do you have any thoughts about that Cardia?
Yeah, I have several patients who use it. I like it. I think it's a lot. I think it's a lot more reliable. It gives you more information than most watches, and it's something that we can use clinically. So I have no problem with that. Like I say too, I think it's really good if patients are engaged in their own care, and if this is a way to get them to communicate their health information to their doctors, I look at it as a positive because I'm getting more information from my patients.
Right.
They are, and then we can have more of a conversation about what to expect. These sorts of things like checking your blood pressure are so important if you have aortic disease.
Well, and I know that Omron is one of the ones that are on the verified website. And so, and Omron now has blood pressure cuffs that are Bluetooth. You can download an app, doesn't cost any money, and all of your results are kept there. So if you wanted just to send it to a doctor, you could, versus having to write them down after you read them on the screen.
Exactly. So. And they upload nicely into the medical record. We use them a lot in our medical records. The patients can send them in. I see them on the portal. It's great. And it's so easy to give feedback that way.
That's great. All right, Josh, we're going to do one last check-in before we let Dr. Prakash go and have some dinner.
Everybody's watching in quiet awe, I believe.
So it is quiet awe. that and they're sitting there eating their dinners like this. Okay, if you have any questions moving forward, please don't hesitate sending them to us at info@aortacope.org or putting them in the comments section. And Dr. Prakash, you always have the opportunity to write a comment back, and we'll send you any emails that we get. This was nice. It was nice to do it. We have not done it in this forum before, a little different than doing it on Facebook. Kind of thinking we should sprinkle it in and change it up a little bit a couple times a year.
Well, sure.
Nice.
If people like this, we can do a little group poll, then we can do a few more of them. I'm fine with that.
Yeah, I like it. And I'll be looking forward to getting the information on your additional research studies. Don't forget, if you're interested in participating in the research study that is to do with your physical exercise, we are counting down to when you can accept additional patients. So check it out. It is on our resource page. If you go to the research link, you will see all the information and how to reach out to your office to sign up and hopefully be chosen in one of the 3 locations, which would be great. I'm like a commercial, right?
That was perfect. I really, I couldn't have done it any better. And thank you for the opportunity.
Thank you so much. We always enjoy having you here. I always learn something new, whether I like what my answers are or not. But now I have to send some message in the portal to my own doctor, and he and I will have a conversation. But thank you again so much, Dr. Prakash. Everybody, don't forget to click like, click subscribe, click the little bell, and share this video, because other people, even outside of the aortic community, are going to derive some information that might be important to them in their own conditions. And until our next live Q&A, thank you again so much, and we'll talk to you soon.
Bye, everyone.